I think the key finding in the article was that men wish to have genuine communication and genuine interactions with their healthcare provider. And for me, when I first read that, it occurred to me, yes, of course, that's the case, and I think that's the case across gender. But to hear them articulate that wish to have that interaction, I thought was really interesting, and I think that, or I wonder, if men felt that they had that genuine connection with their physician, would they be much more open to disclose their symptoms? And would there be less of that normalizing of their symptoms or minimalizing of their symptoms if they felt like they were talking to someone who's a human who really does care about them and their story? And I think that's really important for us to know as therapists, psychologists, psychiatrists, mental health workers, that our patients do want to be seen as an individual, and they all have a unique story that they can share. So I think that a general concern that patients have is access to services, so whether male or female. But I think in particular for the male population, I think they hold on to that stigma around mental illness more so than females do. And that's a significant barrier for them to seek out treatment and to feel that they're being heard. I think that sometimes too, or more often than not, when they do eventually seek out treatment, it's further along in the course of their illness, which presents its own challenges. Sometimes too, when they do present, as mentioned in the article, it can be in times of desperation, and in those moments we have to consider safety, and that may require admission to a hospital, that may require certification, and unfortunately when you treat them in those acute situations, I think their experience is different than when they've had regular appointments and follow-up. And I do worry that when they wait to seek out treatment so far in the course of their illness, to the point that their safety concerns, that their experience in being treated in an acute setting is different than that in more of like an outpatient or primary care setting. I related to a couple of the vignettes from the article around desperation. There was one person in particular that was talking about speeding along the highway, and I've had a few patients that have been in that particular situation where they've done something risky, and it wasn't until they were in that moment that they went, okay, there's something wrong here, I need to seek out help. I think for some of those men who've gotten to the point where they're in desperation, I find that not many of them have actually disclosed what they're experiencing. So for some of them, even coming in and being able to have sort of like a container to sit and talk about what's going on, just having that is a certain amount of relief for them, and that might be in the moment enough for them. But again, we have to be cautious about who I can continue to treat in that manner and who I need to bring into hospital. I also feel that in the medical field that we need to be more aware of the differences in presentation between females and males. And unfortunately, with our stretched resources, speaking primary care level, right now physicians have the ability to primary care physicians have the ability to see patients for a period of 20 minutes to provide counseling. And with men that are stoic and normalizing and don't want to share what they're experiencing, it's going to be a real challenge to get that information out of them in 20 minutes. So from a system standpoint, I think we need to change the way we think about counseling and the way we, the time and resources that we allot to it. In addition, from the study that I did, it shows that even if you have depression screens or posters up in the office commenting on depression, chances are that the males are not going to disclose that. So you need to take the next step and ask them about whether they're having any emotional problems. And if that becomes a regular part of primary care where that's asked, then it doesn't become this foreign this foreign thing that we don't talk about, or the elephant in the room that we don't like to discuss. So if family physicians are able to bring that up as part of their regular check-in, then I think that men may disclose. And I think that may be one step towards changing the culture of talking about depression.